walk through this. So we already have close to 50 people and people are still joining. So I think it's going to be a pretty big group today. Oops, sorry. Let me get back to that slide I was trying to get to. So in order to make sure that we are able to be as interactive as possible, but also limit the chaos, I welcome a certain amount of chaos, but we'll see how to best do this. There is the chat tool, and please feel free to use it anytime. If you want to speak out loud, if
You muted yourself, Jessica.
I don't know how that happened. Thanks. I don't know when I was muted, so I'm going to start from the top. Thanks all. Please use the chat function if you have any questions, any thoughts, anything that you want us to return to, maybe at a time when we're not in the middle of having slides that we're sharing, or if there's something that you want us to use after the fact. We do collect feedback. You can also, happy to have questions out loud, just if you can raise your hand so that we can call on you, just to make it a little less chaotic. We're over 50 people now. We are recording. It looks like we're recording right this moment, so it has started. And we have been committed to sharing the presentations and the recordings and the slides and all of our materials after the fact. And we plan to do that again today. We had a slight, Zoom isn't playing as nicely as we'd like today. So we have a URL for captioning that we're going to share in the chat right now. It is in English and in Spanish. And sorry that Zoom isn't playing as nicely as we'd like, but you will be able to access that here. This is me multitasking. So thank you for your patience. So this URL will take you to, and in fact, I can show you in real time, a screen that looks like this. And you can toggle between English and Spanish. And feel free to use that either as a transcript after the fact or to keep up right now as we're talking and as we're having this work session. We do also have live interpretation. So if everyone can take a moment to navigate to, it's a globe icon that shows up within your Zoom toolkit, and it will have an option for an English or a Spanish room. And so you can choose either English or Spanish. We have interpreters here who are ready. And if we make sure that we're each in either English or Spanish, that can facilitate us having that conversation back and forth for anyone who wants to receive information in Spanish or wants to speak in Spanish and have folks who are tuning in on the English side be able to participate with you. And now I like to use what I'm calling the housekeeping slide as a way also to pass the time while people get situated. It looks like we're starting to stabilize with our list of people here in the meeting. So I'm going to navigate back to the top, and I'm going to go ahead and get started. And I do see a question. You are welcome to use chat or to use a microphone, whichever works best for you. We are keeping an eye on the chat. I am keeping an eye on the chat, and we'll try to integrate questions, concerns, thoughts that I see on the chat as I talk. There might be some that I get to after the fact, but we'll do our best to make sure we're being interactive and that we are not only talking but listening, whether that is by reading or by having an out loud conversation. Both are good. All right. Hi, everyone. My name is Jessica Diaz. I use she, her pronouns, and I work for the Oregon Health Authority. And I'm excited to be your presenter today. for our health-related social needs partner work session. And that is for Oregon's 1115 Medicaid waiver. It is January 2024, so we thought we would pause a little bit together and talk through some of the things that we've done in these work sessions and things we've talked about in these work sessions throughout the past year, and really make sure that we all get on the same page. And we have some interactive components we have planned for looking together through what might work better in the future, how we can continue to make these meetings useful for you all, and what you want to get out of these work sessions. So before we get to the future, let's look backwards at our 2023 health-related social needs partner work sessions. I'm going to share a little bit, just really high level, what we went over. And we also have some information that we wanted to share back about what we have heard from you. Would love to hear from you if you feel like we are missing the mark, or if there are things that you think really resonate with you. And just really to set the stage here first before moving on to our 2024. So first off, we started this series in August, which feels both like a million years ago and like only yesterday. We spent our first session, and it's the only one we didn't record, so it's the only one we don't have a recording of. We really did a broad overview of Oregon's 1115 Medicaid waiver and started talking about health-related social needs, which you'll see in some of these slides, the acronym HRSN. And I'll try to say the whole thing out loud as often as possible instead of the acronyms, but I work for the state, so I sometimes fall into my acronyms. And we started talking specifically about those housing, nutrition, climate, and outreach and engagement supports that are built into this round of our 1115 Medicaid waiver here in Oregon. Also in August, we had another meeting that talked a lot about community capacity building funding and what we knew at the time. And we continued to build it out from there. Now, for today, I didn't pull up the what is the waiver slides, but I'd be happy to point folks towards those materials. I do want to make sure, though, that we continue to stay on the same page about health-related social needs, since that really is the cornerstone of what we are working on together in these work sessions. So when I say HRSN, or health-related social needs, there's a big picture definition, and then there's the waiver definition that we got the go-ahead to move forward with the federal government. So the big picture is anything that impacts someone's ability to maintain their health and well-being. So these things can be social, they can be economic, they can be having a stable place to live, being able to have utilities in that stable place where you are living, having access to healthy foods, the foods that people need to be, sorry, my cat just jumped on me mid-sentence. Healthy foods, diverse healthy foods, making sure people have the food they need to stay healthy. It can range through a whole wide range of services. And I think the thing that really ties these together is there are things that live outside of what we traditionally consider medical care. And so those are the health-related social needs. Now there's this big ecosystem of everything you need to stay healthy, and then there's these small amount of things that we have the go-ahead to focus on in this waiver here in Oregon, in this 5-year process that we're in right now. And so that's where you'll see us call out again and again, housing, nutrition, climate, and then outreach and engagement. Now, we can't talk about programs without talking about funding. And so this graphic is here to try to help us think through the ways in which this waiver gives us the opportunity not only to pay for the services themselves, and you'll see that as the orange part of this pyramid, that $904 million, and also community capacity building funds of $119 million. And these are two different buckets of funding and very technical buckets. I can't think of a better way for my brain to really think about the difference. One is the provision of services. Is a housing support provided? Can it be reimbursed? Nutrition supports, the actual things, the air conditioner someone receives. And then the community capacity building funds are related to how do we get up to speed and have these startup costs covered so that we have providers who are able to provide those services. So the things the providers need to then be able to access that bottom part of the pyramid. And so that was August. In September and October, we talked a lot more about the health-related social needs service sequencing. I think it's the first time we really shared a timeline, and those timelines have shifted a little bit. So I do have a slide that shows our current timeline. We talked about the delivery process for these health-related social needs services. And we started to look into the provider qualifications. And we also looked through a draft service and eligibility need form, which is not a required form, but a form that helped us think through what information is needed to determine if someone is eligible for these health-related social needs. And we also looked more deeply, specifically at the outreach and engagement services. And I have a few slides to sort of jog our memory on what we talked about there. Here's our timeline first. We have phase one, which is the launch of climate services for eligible populations. And you'll see that that is scheduled very soon for March of 2024. Phase two is when housing services launch, and they launch specifically for those who are at risk of becoming houseless in order to prevent more people from entering the chronically houseless population. And that is November of 2024. Phase three is when nutrition services launch, and that is January of 2025. And you'll see that this is the start and things will continue to grow. So we do have populations, for instance, under housing that we are going to continue to build out throughout the rest of our time here in this 5-year waiver. And so these are health-related social needs services specifically as one small part of, not small, small is the wrong word, one part of the waiver. And then also as we think through the difference between outreach and engagement, which is the O&E here on this slide, and some of the other services, really focusing on using outreach and engagement within the waiver as a way to identify and engage with people about their eligibility and their ability to access these health-related social needs services and others. And so you see here a flow that I'm not going to go into in detail today. It was, this is taken from an earlier presentation that we gave to you all, but just to think through some of the ways. And so maybe you can help visualize your role or the role of organizations you work with or collaborate with, not only in the climate, housing, and nutrition services themselves, but that glue that helps people connect to them and helps people determine where they fit in to these brand new things we're able to use Medicaid funds on for the first time. November and December, we revisited the community capacity building funds. We talked in more detail about the grant application process. And in December, we shared an update on the climate benefits. And we also started to dive a little deeper into those provider qualifications and provider readiness. And I have another timeline for us, just to make sure that we're recapping and getting all on the same page, which is we are right now in the beginning of the outreach and awareness campaign for community capacity building funds, which means that you all were ahead of the curve because we've been talking to you for quite a few months about this and having conversations. Very soon the applications will open. CCOs will provide notice to the awardees in July and September. And you see that there's funding disbursement as early as August, and that this is only the first round of funding, and there will be more available in 2025. Now, something that's kind of breaking news, and I am going to pull it up. I linked to a website on this slide, and I wanted to take us directly to it and show you all a little bit of what's now publicly available. We have a community capacity building funds site. It has a lot of great information, and you'll see any place where there's a plus sign, you can expand out that section to learn more, including the information I just gave you, the application itself. Additional resources will be coming soon. And this is very much under construction, but I did want to show you that there is a CCO contact list. And I also see some subject matter experts. So if there's anything I'm saying here that you want to raise your hand and add, please don't be shy. I think that the CCO contacts, the details are still being added in. I did notice that a few of them currently do have direct links and direct information. I believe HealthShare and Trillium currently have their information up. So expect more to arrive on this site as we continue to build out tools and resources for you all. But just know that it's here. We now have things that are publicly available. And I really recommend, if you are here in this session, that probably means that you're an excellent contender for participating in the community capacity building funds. But yeah, I wanted to show you that that resource exists. There is also an inbox, this ccbf.info@oha.oregon.gov. If you have any questions, any thoughts, if you want to get any information specific to community capacity building funds. And thank you, Suzanne, so much for dropping that direct link into the chat for everyone. This is another one of those slides that is really a callback to the information that we recently shared, but just making sure that we remain on the same page. We really are looking for health-related social needs providers throughout the state to really make sure that people are able to receive high-quality, trauma-informed, culturally and linguistically appropriate health-related social needs services, and to receive those timely. So we absolutely cannot do that without our really amazing partners across the state. And so there are some things that we are asking of folks as they seek to see themselves in that role. And there are standards that are written into our agreement with the federal government around making sure that we are making sure providers are qualified and they meet specific qualifications and that they are ready to begin the work. So that's the readiness assessment part of this. Now I'm talking a lot at you and I'm repeating things that you might have already heard in some of our sessions, but we've reached the end of that section and really excited to focus more on what we have heard from you all and to continue to collect feedback and continue this conversation. So some of the key feedback that we've received, and I will say that we have done continued work on many of these things, but we still have plenty of work to do, is that you all gave really great feedback seeking clarity on what it means to be and to become a health-related social needs provider, including what roles and responsibilities that entails, what services are included in the waiver, how we can do this sustainably, what those details are for provider qualifications, how someone gets onboarded as a health-related social needs provider, payment mechanism, and then what are the requirements in our systems, and calling out specifically MMIS, which is a Medicaid information system requirement. And then when it comes to community capacity building funds, eligibility, You all had really excellent feedback around how we build this for smaller, less established, culturally specific partners, how we open this up to maybe organizations who aren't already deeply involved in Medicaid work, who maybe don't have the longstanding relationship with OHA or with a CCO. How do we build a system that really brings in new partners and really prioritizes communities that we have historically left behind? So this is true of the community capacity building funds and true of the HRSN provider lens more broadly. And then something that I think we can continue to do with you all is increase our clarity around which part is that top of the pyramid, the community capacity building funds, which parts are that foundation of the health-related social needs services themselves and that reimbursement process, and how do we make sure that works and works well across the state? We also know we continue to have more work to do around outlining what are the services that are included in the waiver as health-related social needs services, and exactly who is eligible and how we, and the process by which we make that determination. And part of that is really clarifying the process for eligibility. We shared a draft form. What is that going to look like moving forward? You all shared really important information on how we think about our forms and not creating more trauma for folks or making people repeat over and over again information about their needs, their health history, their social and economic situation. How do we make that as trauma informed as possible? And then also there has been a lot of conversation, and you'll see we're making some steps, but there's also plenty to do here around how we and for me at OHA, where can I help relationships develop regionally with CCOs across different organizations, and where is maybe they're not a place for OHA, and we just need to step back and let you all make those connections. So how can we facilitate? How can we get you all the information you need to do that collaboration with your local CCOs, or learn from you all about what collaboration has been working really well? So making sure we can all work together and we can right size that collaboration. And that was my attempt to distill a ton of really, really excellent feedback into a few key themes. And so we've been working hard to be having these conversations with you all, to be collecting what we hear, to get it back to folks inside the agency and across state agencies, and now also share it back with you. So that's something that we're trying to do a better job of as well. And George, I see your hand is raised. I don't know if you wanted to put something in the chat.
Yeah, while all this was coming together, was people with all types of disabilities, especially with the physical and wheelchairs, was we all we were being considered when putting in all this together? And if so, question 2, what is the matrix for the CCOs when they go to do this?
Yeah, those are great questions, and I'm not sure I have a ready answer. I do know something that I have glossed over today, and maybe should have started with more intentionally, is that this 1115 Medicaid waiver, this step of implementation, is not something that folks at the state or folks at the federal government made decisions on and are now showing you. This was a process that we have gone through multiple steps to get towards implementation, with multiple rounds of engagement, public comment, things like that. And I didn't talk at all about that because I got a little bit of tunnel vision focused on these health-related social needs provider-specific conversations we've been having. And so these have been places to really explore implementation of ideas that have been many years in the making. And I think to really answer that first question well, I would need to really return to some of the other avenues that we've been working through. I'm not sure I can do that today, but I do want to make sure that we return to that. And I do know that we do have note takers today, making sure that we're getting that. Did that help or not help? It's okay if it didn't.
It sort of did, but for every time housing comes up, I'm learning through the process that on some instances, people with a disability is never considered, and it getting deeper and deeper and deeper and deeper. And it's become harder and harder and harder and harder for a person with a disability, physically and wheelchair especially, and getting into these type of situations of housing.
Yeah.
There is not some of this focus of what we are coming from, of what's one thing doesn't, how's the phrase work? When one entity works for one, it's supposed to work for all, and sometimes that's not the case.
Thank you for sharing. And I do think these are really important things for us to return to and to not lose sight of. And I do appreciate that you're here and you're raising your hand and actively reminding us of this. And in the absence of having a really clear answer for your really excellent questions, we have noted it, and I'd like to return to that later. Is that okay?
Sure.
Thank you. And what I'm most excited about is that I'm going to do more listening in this next section and less talking at you all. And so one part of that is as we look forward into, I'm going to try to set our focus a little narrowly on this particular meeting series and our collaboration specifically with folks who I hope you all consider yourselves partners in our health-related social needs work, potential providers, potential referrers, and major players in how this rolls out statewide and locally for you all. And as we think specifically about these work sessions, we did have our engagement team took a first crack at some practices and goals for us as a group as we continue this work. And I'm going to go ahead and read these out loud. And then I do also have a blank page. So if people want to interact with this list, add thoughts of your own, if there are ways in which you think that we can better set our goals and our practices together, also very open to that. We thought that some group agreements could help us really be a cohesive group and see ourselves and our value in this work as we move forward. And so some of those practices include staying engaged within these work sessions and with the process. We really do hope that this is a place where you feel is safe to speak your truth, as well as honoring one another's participation, encouraging shared learning. Expect and accept some discomfort and or non-closure. We may not have complete or satisfying answers. There are systems we have to work within, and there are things that we are able to get creative on. And we're likely to come to some answers that might be a little uncomfortable. We might have some situations where we're not all in agreement. And that's okay, and that's part of the process. And part of that is continuing to show up curious. I know that I really want to make sure that I continue to be humble in these spaces. I'm here as much as I am talking. I am mostly here to learn from you, to listen to you, and to see where there are ways in which we can start to build on work that is happening internally, needs and really valuable experience externally, and find a place to meet in the middle that's valuable for all of us. And when it comes to the goals that are here on this slide, is our goal is to value each other fully, to be intentional about how we collaborate, to support each other in learning and sharing information. And so we can all bring our own knowledge here, our own unique experience and skills. Continuous learning, continuously adjusting. This is dynamic work. The answers may evolve as the work evolves. And we really hope to carve out a space here where we can share as much as we can and get fully engaged in this dynamic work. So that's what we started with. That was our own internal brainstorm. And if anyone has anything that they want to speak up or write down that you think may be missing or could be adjusted, I did want to offer us some time to do that. And so I'm actually going to stay on this slide for a couple of minutes. I'm going to mute myself, get a drink of water, and give us some time to sit with this for a little bit. If you would like to interact with the chat to do it, if you'd like to raise your hand, and also if you'd like to maybe check in some other way, very open to all of these, but we want to make sure as we continue this work that we're doing so in a way that feels valuable to you all. And so this is step one of us wanting to really intentionally craft something together. And so I really do welcome things that are not coming from me, especially. So with that said, I'm gonna make good on that and mute myself and get that sip of water. And thank you, Misha, for putting something in the chat. And I will say also, as a way to ground ourselves, making sure that these group agreements are visible to us all at the beginning of meetings moving forward is another practice that we would like to integrate, just to make sure that we feel like we understand what to expect in these spaces. And thank you as well, Eileen. And we're about to get to what I am most excited for today, which unfortunately will still involve me talking, but is to specifically be asking you all questions. And we've also made a survey tool so that you can anonymously share information about how these have been going and how we can make them better. Since it's pretty quiet, and also I do want to say that if anything comes to mind at another time, feel free to let us know. If there's anything that comes in between now and our next session, I'll make sure to integrate that into our group agreement. So there's no ticking clock on this. This is something we can also commit to as one of those dynamic things we can build together as things arise or evolve. All right. Oh, I see some great stuff in the chat that doesn't relate to group agreement. So I'm going to start with the poll questions and then we're going to circle back to some of the more operational questions if that sounds all right to you all. And these are called poll questions, but we actually have a survey tool for you all, and we're going to drop that in the chat very shortly. it's a longer URL than I had expected. I'm also going to go ahead and open it on my screen so you all can see what it looks like. Let me see if I can make this. I can make it bigger. Okay. So when we're thinking about these health-related social needs partner work sessions specifically, we have a few questions, and I'm going to open up each of these one at a time so you all can see the options. I'm sure some of you have already jumped ahead and are actively filling it out, or maybe even done, because it is a pretty short 6-question survey. But we wanted to ask you all how useful you are finding these work sessions so far. And we have a 3-point scale from it's not useful, it's extremely useful, or right there in the middle. If you are finding some usefulness to it, and there's no wrong answer, and I will not in any way be offended. I really want us to improve. We have been recording these sessions with the one exception of the first one, as we were just getting started. We wanted to check in and make sure that we're on the right track with recording them. Are you interested in them continuing to be recorded? You have options of yes, no, not sure, or no opinion. Now, something we did a little bit today, but we haven't done in the past, is including some key takeaways, summaries, what we have heard from you all. We're wondering if you're interested in us integrating that into our processes for this work session, share back with you summaries and key takeaways from previous sessions a little more intentionally. So you can let us know if yes, that's something that you think would be valuable, if it's not something you're interested in, or if you're not sure, have no opinion. We also, as we're thinking about ways that we engage and open up space, we wanted to check in and see if you'd be interested in something that is less of us giving you presentations, and if we should open up office hours, or if that's something that you would be interested in taking advantage of. So if you think that office hours are something that you would like to actively participate in, we have an opportunity for you to let us know. And you may notice we're also playing with having a survey in this. So, and it's been a bit since we have had surveys with this particular body of work. So I was wondering if, like what you are seeing right now, you'd be interested in providing feedback, not only here with us in these sessions, but if you would use surveys, if they were provided after the meetings, to provide anonymous feedback. And then the next question, which we didn't quite ask in here, but if that is something that you would like us to do, we'll probably bring you back the next step of us fine-tuning what types of feedback we can help facilitate happening as well. And then the last question is an open-ended question that you can put in up to 500 characters, which is just any ideas you have about how to make these meetings more effective in the future, these health-related social needs partner work sessions. And we're sharing this now, and I would love to have us have time for you to start to put your thoughts in here, but just know that this will also, I believe, remain open at least for a few days after. So this survey now is not the only time to input, but it will be time limited because we'll have to close it and then do something with the information that we received. So that is our plan. So now that I have walked through those slides, I also wanted to keep this text here visible for us all. And also if there's any way in which you want to interact that isn't built into how we formed these questions, you're of course always welcome to use the chat or to reach out to us in other ways. And I was fully focused on that, but I do see there's been some conversation in the chat, so I'm going to catch myself up on that. I do see we have some internal folks who are on this call who are excellent subject matter experts. So I'm going to see if I can crowdsource some of this a little bit, which I do see a question around the draft documents, the various documents that we've mentioned. I think many of them are available on the public site. And I'm wondering if any of our internal folks, off the top of your head, because you are in this work more directly than I am, have information about any of the assessment documents. I think those might still be coming, but I wanted to double check with folks in the room. If you're feeling brave to chime in. Which it's also okay if you don't. And I can actually, I think maybe I'll point us back to the website I was just looking at, and we'll look around together for a second, because I think that there are related documents, maybe not the ones that you've called out specifically, Colleen. I think one really good resource is here on the Community Capacity Building Fund site, which is we have a infrastructure protocol document that I'm going to open up so that we can look at it together for a second. Oh, and apparently I was looking at it and I'm all the way at the bottom. There's really great information here about, and when we're talking about infrastructure, that we are calling that community capacity building funds. And so you'll see this is our final attachment J, using some CMS language. Around timeline, around the application process for those community capacity building funds. And I'm sorry, I'm scrolling through rather than being complete, just so you can see what's in here. Some information about monitoring and oversight of these funds. Who is eligible? And I know this is information we've shared in past sessions, but I know I also didn't talk in detail about it today. The ways in which these funds can be used: technology, development of business or operational practices, workforce development, outreach, education, and stakeholder convening. And then it goes into more detail on these different categories and some expenditure amounts, funds specifically expected in these different allowable use categories. And I think this relates, but it's not exactly what was being asked about. I know that there are aspects of the eligibility screening that are very much in flux, but are exactly the kind of things that we are hoping to share with you all very soon. And you'll probably hear us talking in the phrase that you'll probably hear me come back with in a month. In fact, I think it's on one of my slides, is provider journey, walking through the provider journey. And I think that encapsulates a lot of the pieces that we have been seeking to share, and really hoping to start walking through that journey together about how an organization onboards, how they provide the services, what the expectations are, and going all the way through payment, reimbursement. I doubt we'll get to all of it all at once, but just know that talking through what it means to be a health-related social needs provider and walking through that journey together is a place we expect to go very soon. And then I think another part I'm seeing of this, and you all can let me know if I'm missing the boat here, but around that readiness assessment pieces in the Community Capacity Building Fund application process, by which an organization can show that they are able to provide these services, they're ready to provide these services, and that perhaps that they might be a good fit for community capacity building funds for places where you are identifying gaps. And I'm going to pause and see if that answer helped at all. And I hope it did help, but I also know we're going to continue to walk through this together. I also see some resources in the chat. I think, oh, there it is. Yeah, that's that document I was just sharing. And there's also a FAQ. I think we have 2 FAQ documents. I think we have this one specific to community capacity building funds, and we also have one that is broader across the waiver on our public site. So I hope me poking around helped a little.
Hey, Jessica, I want to suggest that you click on this link right here, OHA's 1115 Medicaid waiver website. That has more resources that are beyond community capacity building funds, which might address some of the questions that are in the chat.
Thank you so much.
Yep.
And I'll let you all know, I visit this website just about every day just to make sure that what I'm saying is actually aligning with what is real and what is out there. There's a lot of great information on our Medicaid 1115 demonstration waiver website. This is the one that's specific to this 5-year process. And we do have a few different, waiver websites. This is a great place to start. Incidentally, it also links directly to that page I was just sharing with you about community capacity building funds. And I believe it was also recently shared in the chat by some of our folks supporting this session. Yes, so in English and in Spanish. And all of this is to be interactive while also giving you a chance to fill out the survey. But with that said, I'm also going to scroll back up and see, I think there are some other things we can potentially speak to. Up here, I'm going to have to check back in with my folks about an HRSN collaborative. I'm not sure. I know that this is a place where we are collaborating with around health-related social needs here, this work session. There's a good chance that I believe there are also some CCOs that are launching some regional work around this. I don't know, Pierre, if you want to speak up and talk about what you've been hearing. And I can follow up offline as well. I want to learn more about this and make sure I'm connecting the dots correctly. I do see a request for recording and slides, and absolutely will make that available to all of you in a follow-up email. And also, we will actually, here, sorry, I'm poking around my own slide deck. This is what I was looking for. January has been a wild month so far. Thank you all for your patience. We did address, we changed the date because it coincided exactly with when an ice storm was supposed to hit a large part of Oregon. We thought it'd be better to have conversation at a time where people are not experiencing that, staff and partners and community alike. So thank you all for your patience and your flexibility. We are seeking to make this a more regular occurrence where you can rely on. It will be on second Tuesdays, 1 to 3 p.m. once a month. That is our plan moving forward. I did tease, but it's here in writing. So we are planning to really take the lens of the provider journey as we continue to work with you all and share what we know and solicit feedback and listen to you all as we make more clear what it looks like to become and to be a health-related social needs provider. And so expect that right now that's listed as the February topic. Something tells me it's going to continue beyond February because that really is the central work we're here to do today is make sure that us working on the waiver are building something that you all see yourselves in and a role for yourselves, and that we are doing so in a way that really does open up opportunities for you all as organizations that are either providing or otherwise involved in these health-related social needs, specifically the climate, housing, nutrition, outreach, and engagement pieces that we are allowed to start using Medicaid funds to reimburse for. And just know that we also, in addition to these sessions, which are really focused on health-related social needs and that partnership that we're seeking to make, we also do have what we are calling the All Come webinars that also have been happening monthly. We took a break in January, but we'll be starting again in February. And so we'll make sure to share with you all the registration links and the information for future sessions there as well. And I did want to open up the floor again for sort of more broad, less structured question and answer. If there are things that you all want to get our attention around, priorities you have, we do always use the chat to help us build our future sessions. And so in addition to the very structured survey that we offered today, wanted to open it up. And I see a hand, Emily.
Yeah, hi. I apologize. I am very late to the game in attending these sessions and just started getting these email notifications, figuring this would be helpful for my work. I'm a pediatric social worker at Dornbecker Children's Hospital, work with hematology and oncology families, and started wanting to get information about this waiver coming through, trying to figure out if any of the families I work with who have obviously Medicaid would be eligible. And so I was just reviewing the protocol that was shared in the chat, and I was trying to figure out, I was looking at age eligibility, and I saw a lot of members 19 to 26 or children below the age of 6. And I guess in the population I work with, it's I'm trying to figure out, like, if for example, I have many families who are potentially facing eviction because parents haven't been able to work because their child's been in the hospital or clinic appointments, what have you, and are facing eviction. That's a very common likely thing that happens. And specifically in the hematology population, there aren't a lot of charitable nonprofits across the country who offer financial assistance like there are in oncology. So if I was trying to help a family access funds through their CCO for something like making sure they are able to pay rent and don't end up getting evicted, am I looking at that service under the parent who has to be between the ages of 19 or 26, or the child who is sometimes older than 6 but not 19 to 26? That was very long-winded, and I'm not sure if that made sense.
No, thank you. And thank you also for the context around your question as well. I will offer a partial answer only, but we also have folks who wrote that down, which is that when it comes to the health-related social needs services specifically for this waiver, you were probably looking at this list or some list that looked like it around the populations that are covered. There's something that I need to say that I don't think is explicitly written into this presentation. I'm just going to say it out loud, which is first, step 1, someone has to be on the Oregon Health Plan. Someone has to be on Medicaid, on OHP, before we are able to apply any of these waiver covered services, because it is a Medicaid waiver. So I want to say that out loud, even though I did not write it down. And then I don't have really technical answers around where we are looking at individuals versus households and exactly how that eligibility shakes out. But I do know that this is the place we are starting from, and that I think that's a really great conversation to continue to have, and for us to continue to build out. And I think that I talked about provider journey. I think we'll also be spending quite a bit of time walking through what we're calling member journeys. And so that gets more into the process and the eligibility factors, which is my non-answer, but I hope it at least starts to situate us in where we can go in the future. to get more concrete answers. Did that help?
Kind of, I guess, like I'm just envisioning this big gap when it comes to myself, but also various other pediatric social workers at Norm Becker, where these kids have very chronic health care needs, and some, identify in rural communities, houseless already communities, Black, African American communities, Asian communities, but aren't, 19 to 26 and aren't below the age of 6, but are still facing, houselessness, or still facing food insecurity, maybe haven't entered child welfare, but are at risk of. And then I guess curious, if they're 10 and are in child welfare, do they then qualify, even though they're not 19 to 26 or below the age of 6? Like, just trying to figure out who the kind of targeted population is, and how does it fluctuate?
Yeah, and I'm going, instead of me, engagement person who is not a SME, a subject matter expert. Sorry, I used another acronym. I'm not going to try to answer it now, because I think that we can do a better job of coming back with something that's more clear for you. And I know that there are guidance documents and various things being made, and I'm going to check in with the folks who are making them to see what we have that can be shared, because I think that, of course, everything's connected. So we can't have a conversation about any part of this without also delving into other aspects of what's being built, what the limitations are, where we have to work within a very specific framework that does, like, there are gaps. I'm trying to think of how to say this without either trying to be too rosy or tactless, but this is not a full solution. It needs to work in conjunction with other existing programs, and there likely will be things that we discover together that are continued gaps based on the structures that we have and have to use within Medicaid. But I think it's something we can explore in more detail when I have materials to support me, which is my state answer, but I don't want to speak out of turn. And also, I did want to say right off the bat that there are programs, these things are scheduled for the future that we're talking about. There are health-related services for CCOs that they are actively working with members to provide right now. So it's never too early to reach out to a CCO and ask what they can provide and how to best work within their structures right now. So there absolutely are things that could potentially help these families right now, and I wouldn't want people to wait for this solution when there are other solutions out there as well. That's what I got today. I do see some questions specific to how much funding is going to each CCO and how CCOs are reaching out to community-based organizations. Lisa, Suzanne, could I put one or both of you on the spot to talk a little bit about where we're at for how people can best collaborate with their local CCOs on community capacity building funds?
Yeah, definitely. I'm happy to answer those questions. So while we have a total of 119 million over this 5-year demonstration, we do have yearly annual amounts of this type of funding that can go out. The first year is 38 million in total. And so that has been allocated to CCOs, an amount by which they can award. We have not transferred those funds to CCOs. That money will go out to in grants through the CCOs to the organizations that they award. And so each CCO has been allocated an amount by which they can award those grants up to a certain limit, which totals the 38 million. And the amount each CCO gets depends on the amount of members, as well as we have a little bit of adjustment for rural and urban CCOs. And then the second part of that we have very specific requirements that we're asking CCOs to do in terms of getting awareness out to organizations in their service area for these funds and how to apply for these funds. Suzanne, do you want to put that in the chat? It's outreach, and we're calling it outreach and engagement, but it's outreach and engagement specifically about this award process and these grants, how to apply. Each CCO has a point of contact as well as a website. And so we are populating our OHA CCBF website with that information. I don't think we have all of it yet, but we are working on getting that for everyone. So there's also on that CCBF website a link to where CCOs are located. So if you're not sure which CCO would be the appropriate CCO to reach out to in your area, you can look at that map and that can help. And then if you still are unsure who to contact, we do have a direct email, and you should send the question to us and we can help connect you to the right CCO. I think I answered all of those related questions, but feel free to chime in if I did not, or add some more to the chat.
Thank you so much, Lisa. Let's see here. I think I see a hand, George.
I was told that thing is 2-3 years ago that the Medicaid 1115 was supposed to have stopped in July. Number one, why is it still being added on more to it? And two, with now the CCOs being part of this, how is that going to integrate into their upcoming 5-year contracts?
I have a partial answer for you, which is, and goodness, it's almost always a slide in the beginning of this slide deck. And I thought, I'll skip it this time since I say the same content every time, and I'm wishing I didn't, which is that the waiver, the 1115 Medicaid waiver specifically, is a 5-year process that repeats every 5 years. And every cycle, we bring a different set of things that we want to try doing differently in Oregon within our Medicaid systems. And we work with the federal government to get an approval for what we get to try this 5 years. And so I'm wondering if part of what you heard was the end of the last 5-year process and the beginning of this one. So we've had 1115 Medicaid waivers since 1994, since we built the Oregon Health Plan, and we continue to demonstrate new ways of doing things every 5 years. And some of these things become our business as usual, and it becomes a central part of our Medicaid plan here in Oregon. And then other things we continue to work on and to reevaluate and to change how we do the work. So as we talk about the health-related social needs here, this is one aspect of things that we are seeking to do differently here in Oregon. And the CCOs were also, they began as part of our waiver process and are now how we do business here within Medicaid here in Oregon. So once again, I have a partial answer. This is my understanding. I don't know if that fully answered, but I hope it helped.
It does, but as far as the contracts, I'm curious, how's that gonna?
Jessica, can I provide some information on this?
Thank you. I'm not a CCO expert.
So I think what might be helpful is to understand that the 1115 demonstration waivers are requests by states to the federal government to waive Medicaid rules and requirements. So where each state or if a state wants to request for 1115 waiver, they have a very specific set of requests for authorities that they would like the federal government to what it's called as waive. So we want to do it in a slightly different way. And so we go through that process. This is our 1115 demonstration waiver, which is regulated by the federal government. And so that regulates Oregon's Medicaid program. Our CCO contracts have to be in compliance with those federal rules and requirements. So our next contract, which you may be hearing about coming up, will need to be aligned with the authorities and with this waiver. Just like, you know, every state, if they have a managed care organization, they have to be in line with federal rules and requirements. So you've got the 1115 demonstration waiver, which provides us federal authority. And then we have our state contract with our coordinated care organizations. And so that's how they work together.
Thank you, Lisa.
Okay.
And I do see that Suzanne has put some more information in the chat as well. Since this will be a recording that people may experience without the chat, I'll say this out loud as well. More information on CCO obligations for outreach around the community capacity building funds. CCOs must publicize the opportunity to apply, including making a contact specific to community capacity building funds known. 2, use community and culturally specific channels to outreach to folks. 3, conduct outreach to varying types of organizations. 4, outreach must include regular email communication to specific types of organizations, webinars to interested parties, and 3, CCOs must report to OHA on their outreach activities. So there are additional requirements and expectations that are placed upon CCOs. And also not all, like, we're here too, sharing information and hopefully pointing you to the right places as well, so that you don't feel like you have to fully just wait for a CCO to reach out to you. We have that website that will continue to have more contacts and information on it. And expect that there will also be plenty of information in our newsletters. We have an external newsletter, and we'll be shouting from the mountaintops that this is available, and we're continuing to share here more details as we continue to have them. So that's something that I gathered. It actually became much more clear to me when I was looking back through the work that we've done together in 2023, how many of our sessions where we brought up a topic, we learned more, we came back with more information a couple months later, and I think that's a thing that we're going to continue to commit to. Suzanne.
Jessica, there was a question in the chat that I just wanted to respond to. It was just to me, but someone asked about what does making a contact specific to CCBF known mean? And what I meant by that was that each CCO will have an contact information specific to the community capacity building funds. And on the website, the community capacity building funds website that Jessica shared, under each CCO's name, we will have that link of that contact where you can email directly and get more information from that CCO. And as Jessica shared, we have the information for Trillium and HealthShare, but we're expecting to fill it up with the other CCOs here shortly.
For good measure, I'm dropping it back in the chat because I know the chat has been very active, and so it might be hard to find things that were further up the list. Also realizing I have a slide that has some information about ways to stay connected with us more broadly as well, and has that link to the waiver newsletter. Give me 1 second. I feel like I want to make sure this link works because I had some trouble with it earlier. But just know that this will also be sent your way in the follow-up information that we share. But I want to double check that this link works. So I was going to send it your way, but I don't want to send you a link that does not function. So I'm going to double check that live. Thank you for your patience. I want to see if there's anything else that came up with this that you want to make sure that we either log for a future session, or we might have folks who can answer some of your questions now while I check this link. Yeah, our link broke, so I'm going to go find you the right one and put it in the chat. But I do see that, actually, I think we might. Thank you all for your patience as I work to keep up with this chat. I do see a question about how much of the funds are allocated specifically to housing, and I do not have an answer, but I will bring that back absolutely to see what information we have on the breakdown of the funds. I know that I saw the community capacity building funds breakdown, but I'm not sure I've seen it for that other that foundation of that pyramid. But I do want to say out loud that I see your question and we're logging it. And then I see a question about community capacity building funds, and may a community-based organization apply? When applying, can they include needs from a partner CBO? So questions around partnerships within and across organizations. I wonder if Lisa or Suzanne, you have any information there?
It sounds to me like the question is, can organizations apply together or collaboratively? Can you submit a collaborative application? And that's allowable. It's, certainly like with any application, you just need to specify which organization will be doing what and for which purposes. Just want to make sure that you put forward a really clear application about using the funds and making sure you use them in the allowable categories.
Thank you so much. Can an organization apply with more than one CCO?
So great questions. And you can apply to more than one CCO, but you need to ensure that you're not requesting the same funds for the same purposes. So there may be multiple CCOs that you'll want to contract with, or you want to provide these services for. You just need to ensure that the funds that you request are not duplicating, right? So that you're using the funds. There are different categories, and there could be certainly some different uses of the funds that make sense. So you just need to make sure that they are different uses and not duplicating the requests. The other thing that may be helpful is to think through, there are multiple years of this funding, so it may make sense that you'll want to request some funds for certain uses from one CCO, and then later on make another request to another CCO. So there's a few different strategies. I do think it may be helpful to reach out to the specific CCO in your service area or service areas that you're wanting to submit an application to, and talk to them about the best strategy. CCOs have the ability to kind of prioritize where these funding is, and so that may help you also determine which CCO you may want to apply for. They are building networks, and so it really depends on where they need to allocate and direct these resources, what they may want to prioritize. So I would really encourage you to reach out to the CCO in your service area or service areas and really talk to them about how they're prioritizing within domains, so housing, climate, nutrition.
I see a follow-up along that same vein is, are there ways in which CCOs are prioritizing different HRSN services at this time?
So we are not requiring them to prioritize. Again, there are such differences across the state in terms of provider networks. And so CCOs really need to look at their provider networks and where they need to allocate resources. So they do have the flexibility to do that. We have listed priority populations, and I think that was on a slide earlier. And what we're really looking for them to do is to ensure that organizations that serve those populations, you know, that they are really reaching out to ensure that they're included. We have asked them to really prioritize adding new providers to their networks. So not just the existing relationships, but adding to those relationships. So we are really hoping that they can broaden their networks to ensure, again, those priority populations are being served and included in these funding so that they can get the resources needed to be providers.
Thank you, Lisa. Ooh, okay. I think community capacity building funds continues to resonate with this crowd, which is a great sign, actually. It means that we're talking to folks who are actively seeing yourself potentially here, which is what we're here for. I do see that, Suzanne, I keep going rogue and just bringing up resources instead of sticking to my slide deck, but I did see there is a question around being a current Medicaid provider, and instead of me going rogue, I'm just going to point you towards the FAQ here. You don't need to be a current Medicaid provider to access the community capacity building funds or to provide services. These qualifications for HRSN providers are slightly different from a traditional Medicaid provider. That does not mean that Medicaid providers are not eligible to apply. So I do see, and hopefully I paraphrase this correctly, and Lisa and Suzanne can keep me honest on this if I, there are going to be MMIS aspects of this work, and I think that's going to become more clear once we dive into the provider journey in more detail, which will start next session. I'm not sure, I hesitate to promise we'll make everything crystal clear by February, but I think that's something that we can continue to show more details on and really get to a shared understanding. For now, I would say this FAQ and the one that's built into the main waiver website are probably the best, most accurate pieces of information. I hope that was useful. I do also see, similar to the question about housing support funds, like what around climate has been sorted and can we share? And that's definitely something I would also want to bring back and see what I can find from our internal folks. And I want to thank you for asking that question. And Stephanie, yeah, please chime in if our answers are not full or complete, and if there's additional stuff we can talk through.
Not being a current Medicare provider, I don't know what MMIS is.
I think it's Medicaid Management Information System. Does that sound right? People who know acronyms? Okay.
Yes, it is.
Thank you. Oh, Mary, you're here too. We have some very smart people in the room. Long story short is it is a tool by which Medicaid providers are able to bill for services, and it does a lot of other stuff too. But it is a specific tool. I believe ours is built by IBM, if I remember correctly, to manage many aspects of Medicaid payments and eligibility. Not eligibility, but enrollment. I'm going to correct myself there, because it's also a place where Medicaid providers see who is on OHP at the moment. So I have no shortage of things to bring back and to get more information on. I'm looking through the chat. I do, maybe I should frame this as a question instead of me thinking I know the answer. And this is a question once again to Suzanne and Lisa. The funds for community capacity building funds, let's say you have more than one CCO in your region, who you get the funding from does not determine for whom you can be in network for and act as an HRSN provider. I meant to form that as a sentence and it came out as a statement. Is my statement correct, Lisa?
That is correct. You do not have to request these funds from a CCO to become an HRSM service provider, and you do not have to request the funds from one CCO and, only be a service provider for that one CCO. These funds are really intended to support future HRSM providers be able to, get to where they need to be to deliver these services. So it's really, somewhat agnostic of the CCO. It is really about getting resources to providers that can join networks. They are able to join as many networks as makes sense for them to serve people in the area. So that, could make sense for some to have a longer, depending on the type of services you're providing, that could be a wider service area or a more narrow, depending on what the services that you're providing. So there really isn't a limitation to contracting or being awarded a grant to provide eventual HRSM services. They're really very separate.
I do want to point out, because I am looking at the FAQ and I guess forcing you all to look at the FAQ as well right now, I do see there's even a line here around what if you are working primarily with fee-for-service members, and what it says here is that the CCO to apply to is any CCO that shares your service area. And so just to sort of further reinforce that this is not about specifically building a network, this is about building capacity statewide. And so we are not looking for this one-to-one relationship with funding and CCO networks. We're seeking to make as broad and robust a network across the whole state that we can. And this is a mechanism by which CCOs are helping us to do this work. And I see great stuff in the chat that I may or may not have done justice. But I really want to, if I have to say it 5 times, I want to say it 5 times, is in order to apply for these funds, that does not mean you are locked into a specific CCO network. That is not what we're seeking to do here. And you as an organization get to choose how you are going to interact with us on these health-related social needs, whether that's within the funding here that we're talking about in more detail, the longer term provision of services. There's not only going to be one way to interact with us on this. And I also saw some questions around like exactly which services will ultimately be provided. And it's not that prescriptive at this point. I believe we just need to know that you plan on providing at least one of the covered health-related social needs services that are included in this round of the waiver. And I feel heartened that Lisa and Suzanne did not jump in to correct me. So I think that that's a correct statement, but I do defer to them. George, I see your hand.
Yeah, I got a invitation to be in on the conversation of OHA and the bridge for Medicaid services. Is that bridge that people are not into CCOs and stuff? Is this going to be tied into that bridge that OHA wants to do?
Oh, I have not been working very much in the bridge program work, so I cannot. Is there anyone who is internal who can? Hi, Lisa. I'm so sorry. I don't know the details of this. I do know that it is another initiative that is really important that we're working on. Lisa, do you have extra context?
I do. I'm slightly afraid of answering this question because it gets a little wonky in that this is expansion. It's going to be a part of the waiver amendment. But I guess what I want to clarify is that those populations that were listed in an earlier slide that indicated the eligible populations, those will always be the eligible populations. They will not change. Those are the federal authorities I was referring to that identified those HRSN services covered populations. That does come from the federal government, and that is something that will not change. Does that help? So it will be these populations that will be eligible. And what we will continue to update you all on are which services, when services will be implemented through this, when they'll be available for these populations, but these populations will not change. Does that
At
help?
least in these 5 years for this
In
part
this,
of the waiver.
yeah, in this demonstration. I'm just trying to hopefully narrow it for folks so they can kind of, I'm not sure if that helped or it just made it too wonky.
Well,
So I apologize.
it did help, and I didn't want to put you guys on the spot, but I know that there's going to be a lot of questions about this bridge that OHA wants to do to, and see if it's going to go into this waiver. And there's going to be a lot of questions.
I think I
Thank you
have
for the
some learning to
question.
do. And I do also just want to acknowledge that we're trying to focus on an aspect of this giant set of things that is Medicaid, which isn't, and that doesn't even bring in all of the other supports and services that people are receiving or are potentially eligible for that live outside of the world of Medicaid here in Oregon. And so every time we try to narrow down and focus really specifically on one aspect of this, that exists at the same time as the holistic needs of people beyond what we are building right now in this really specific way that we have been given the go ahead to try something new. And so there will be times where we don't have full answers or things may live outside of the expertise of the folks here in this room. But we do still appreciate whether it's making new connections that we need to get up to speed about, or other ways in which we can bring in or redirect you to folks who might have the information you need. I cannot promise we'll always have that one-to-one line, but if there are aspects of this work session that you want to go in a direction that we can't go today or in these sessions, please reach out to me and we'll see what we can do. Whew. This has been, we tried something a little different today, and you all can let us know if it worked or not. But this has been a really interesting session.
I just have a quick question. I had received a presentation on the bridge program, and it says that it will not cover health-related social needs. Is that different than the health-related services?
I need a slide about health-related services versus health-related social needs, and I need to share it every time I talk with anyone, internal or external. I feel like I keep reminding myself I need that, and I'm physically writing it down right now.
Because it says it won't cover long-term services and supports or health-related social needs.
And that is the same thing. I think it's just more clearly said in what you're reading. I was trying to state that, but that is the case. So the complicated thing is that it will be within this waiver. It will be an amendment to this waiver, but it does not mean that everything in the waiver falls under the bridge. So this population will not change. It will be a part of the amendment to this waiver. That's how that will get authorized. But it does not mean that every authorized authority within the waiver. This is why wonky people should not always talk. So I apologize because I'm making it more confusing, but what you said is accurate, is that this population will always be the population that can receive health-related social needs in this demonstration. That population is not going to change, so would not include the bridge, which is not listed here.
Okay.
I apologize, did not say that very well. I'm getting into much more of the technical aspect of federal authority, and it's not helpful, so I apologize for that.
Okay.
I do appreciate, Lisa, your willingness you're really taking those group agreements we just did to heart about living in the discomfort of places where we're trying to be open and transparent with uh, the limitations of, I'll speak for myself, the limitations of what my brain can hold at any one point in time. Sometimes when we get into work this massive becomes a problem for me, and I have to go read up on this before I could speak to it. But I do really appreciate you showing up and chiming in, and I think I'm gonna leave it with that. I need to learn a little more about the bridge program so that I could speak to it in the future, because I don't want to say anything that's wrong. And I do see.
Yeah, you can have people
Yeah.
on bridge that are at risk of homelessness, right? But they still
Mhm.
wouldn't qualify for the health related social needs. So it's confusing when you say that this is the population that would qualify, whereas many of those probably wouldn't end up on the bridge program. But there are some of those that would, because again, you can be at risk of homelessness and still be in the bridge, but you still wouldn't have access to health related social needs. Is that correct?
Yep, that is correct. And this is so helpful because it really helps us to understand how we need to communicate this, because it gets complicated pretty quickly. So this is helpful, and you're correct. They would not qualify.
I was like, I want to ask more questions about the return, but I'm going to save that for another time because I want to understand this better. And I think another part of what, and I haven't said this explicitly today either. I often say this, but I want to say it today. I mentioned that in order to be on this list of health-related social needs covered populations, step one is to be on OHP, on the Oregon Health Plan. And the part I didn't say out loud before is that this is inclusive of the Healthier Oregon population. And I think this might be where the distinction around bridge plan, OHP, what we sometimes call internally OHP plus, like the full benefit package, like there are different aspects of how Medicaid works in the programs. And I haven't gone into that, and I don't want to do it today, but I'm wondering that maybe I can chase down some information that'll help clarify it. But yes, you have to also be on OHP first. And I did want to say out loud, because I usually have it in the slide and I didn't today, that is inclusive of the Healthier Oregon population, which is a group of folks who, regardless of their immigration status, have access to full OHP benefits here in the state due to work that has been done within Oregon. And that's a commitment from us at OHA to include that population, which is not the question you were asking, but one that came to mind and I wanted to say out loud. And George, I can't remember if this is the same hand or your hand is newly raised. I'm sorry, I lost track. But if you want to speak up.
It's new.
Okay.
Now, with individuals transitioning to dual status, Medicaid and Medicare, there's many phases of Medicare. Does this also include Medicare Advantage?
I would have to go get that answer for you. I'm not sure of the exact details. We need a deep dive into this topic as its own focused session, I think, because I don't want to do this halfway. Lisa, I saw you.
It's really about the eligibility for Medicaid. These are all Medicaid benefits and services. So it really is about someone on Medicare being eligible for Medicaid and becoming a dual eligible with Medicare and Medicaid services. And so that's the piece that turns on this benefit for an individual, is when they are eligible for Medicaid services and then they qualify under one of these qualifying aspects, right? So for those individuals, there are specific HRSN services that they could qualify for. So they first have to become Medicaid eligible, and then they have to meet the requirements for receiving an HRSN services, which we have some complicated slides and need to provide more information about that. And I'm going to take the cue from Jessica not to get out ahead of the content of today's session. But that's the key for the duals, is that they have to be Medicaid eligible.
I'm pretty sure you're going to be asked more questions about the Medicare Advantage, because like I had mentioned, there's a lot of Medicares now, and with Medicare Advantage coming up, there's going to be people asking, well, if they're Medicare Advantage, is this going to apply? I'm pretty sure.
Only if they qualify for Medicaid. It has to be the qualification for Medicaid that allows them to receive these types of services. The Medicare, they can be on Medicare, but it is only once they are eligible for Medicaid that they can have access to these services. It's the Medicaid piece.
Okay.
I just realized, sorry, I accidentally clicked to the wrong portion of the presentation, but we're back now. I did, sorry, this was many topics ago, and I'm gonna get it again, but our tiny URL broke. I noticed this very recently, and I didn't have a chance to update this in time. So instead of the URL that is listed on this slide, I wanna make sure that if you are interested, you all are able to access our external newsletter, really focused on the 1115 Medicaid waiver. So that is the URL in the chat. And I will make sure this slide deck gets updated before we send it out to you all. I see interest and requests around having regional CCO inclusive sessions, and I am absolutely going to bring that back. I think a question that I have for myself to think through is where it's useful for OHA to play a role in connecting folks versus where we need to get out of the way and let you all make connections, and how we can help facilitate without, I don't want to be central to this, I want you all to be. And so that's just something that's on my mind. But I think that we absolutely will bring this feedback back, and I really am interested in continuing to explore the ways in which you all feel like you are having success connecting to CCOs in a useful way, and the ways in which there might be ways that we can find solutions and find new ways of building those relationships together. And also, I'm gonna click through all my slides before I forget things that I want to absolutely say, which is we do still have a few minutes if there are questions or comments, things that folks want to make sure we're talking through together. But I also want to make sure that as we start this new year, that I do take a moment to thank you all for being here today, for continuing to be here. For folks who are new, thanks for joining us. I'm sorry, this was probably kind of an interesting one to head into first because it was a lot of recap without going into as much depth as we normally do on the specific topics. So thank you for hanging in there. And just know that part of what we will send your way is a list of all of our previous recordings and materials. The one thing I will warn us all about collectively is there are aspects of the timeline that have evolved. So that's why I made sure to put timeline slides in this presentation. If you see in any older materials a slide deck that has a different timeline, just know that use the most recent one, and that will be best. And I also want to, I just want to take that moment to thank you. This is not me saying we absolutely have to hang up and end right now, but I just wanted to go through all my content and then maybe hang out for a few more minutes to see what else is rising to the surface for you all. And I do see folks are also heading to various places. All right, I see hands. I think I saw Sherilyn. I think I saw your hand first.
Yeah. Hi, Jessica. Happy New Year.
Hi.
You were asking earlier about like other topics that so I'm one of the CBOs looking interested in becoming, or at least learning if we are ready to be CCO provider, and then eventually build up the capacity and the resources we need to also be a Medicaid provider. So for someone like us who started out, we are grassroots, started out 3.5 years ago. Our services now are barrier free. So we don't ask for insurance, we don't ask for proof of income, but we do have that data because of the way we do intake. It would be helpful if maybe you can link us up or provide or invite a presenter from an established organization who maybe can share an experience about, what that process looks like for some small CBOs like us. Because at the end of the day, after doing all of our research and due diligence, we may learn a lot quicker through somebody else's lived experience that perhaps this may not be worth, or it wouldn't be the right fit for us, if that makes sense. So we can read up on all these information, we can take a shot at applying for grants, but maybe there are some pieces of information that would be good to hear from those who've been there and done that.
Thank you. I love that idea. I feel like we're in an interesting world here with the reason why we have this really focused look at what does it mean to be a health-related social needs provider is because I don't think some of these things have been done here before. So I'm gonna have to think. There must be analogous situations that we can explore more. And
yeah, and I actually really like that, you, or was it Lisa, who explained how 1115 waiver came to be. So I appreciate that about the state. And then it got me thinking about a specific nonprofit, Project Access Now, because like us, they also provide a donated benefit, and they do screening to find out if recipients or clients have insurance, which then determines, okay, what will they be eligible for? Will they tap into their donated benefit, or will they tap into insurance to get reimbursed? And I know from other fellow nonprofit executive directors, program directors, I've heard stories about how reimbursements can take a long time. And so for an under-resourced organization, CBO like us, that is something that would be helpful to know, right? I hope that makes sense. So like someone from Project Access Now being invited to speak about their model, that they don't just provide that HRSN service and get reimbursed through Medicaid and other CCOs. They also have what MCK provides, which is barrier free, available to those in need, don't need to provide proof of ID or income. I think that would be a really great learning for some of us.
yeah, thank you. I don't suppose anyone on this call immediately wants to volunteer. I could carve out some time for you. Yeah, okay. I'm energized. Thank you. That wasn't an answer, but it was a thank you. Sometimes that's the best I got.
Yeah, I'll just add that's really helpful feedback. I mean, our ongoing development in other spaces is thinking about technical assistance and learning collaboratives and series that we may want to provide, not only in the beginning, but ongoing, because we'll, of course, always want to be building networks and have needs across the state. So it's really helpful to hear that that's something that you all think would be useful. So appreciate the feedback.
Absolutely. Oh, and Emily, I see your hand is raised.
Yes, thanks. I forgot that second step of unmuting. I was wondering if there's a place for more defined definitions under, again, the populations who are eligible. So just reading the bullet points, thinking like individuals facing homelessness or eviction, is that individuals? Again, I'm trying to be creative and figuring out how can I help families access or know where to go to access these funds in the future. Is it sufficient to say the individual I know of is the child in the home who's really the parent, or another one was like children involved in child welfare? Is that an open CPS case, or is that like a reunification? We're 6 months a year into the case. There just seems to be some broadness to some of those definitions, and broadness is great because it means some of those gray areas get covered. But curious if there are actually more defined definitions that would then make it maybe more difficult for some of these gray incidences to be included.
Oh, I know I've seen a draft document. I know there's a special terms and conditions document, but I don't know if any of them are definitive at this point, or if they're more roadmaps we're still. I'm going to peter out on this, but Lisa.
Yeah, so we are just at the point of finalizing the type of detail that you're looking for climate. So climate is the HRS and service domain that will be implemented or will be available first, and that is in March. And so we are very close. I believe by mid-February we can provide that level of detail for climate, and then we can start sharing the development for how the services and the populations will be defined for nutrition and for housing. We can share that for your feedback throughout this year as we further define them. But there is a lot of related work to how we define those. So we need to develop, again, this is all new, and we're one of the first states working through this. So we need to develop fee schedules and service definitions and all of the things that you're looking for. We're really in the process of developing them and looking at them from many different aspects. So that is the type of detail for nutrition and housing that we can begin to share later in the year. Climate, we can share some of that specificity probably by the end of next month. I don't know what the schedule is for this series, but we should have that detail by the end of February.
Thank you. I guess a follow-up question I have then is, I'm trying to sort for myself kind of the different names for different things. So yes, currently I can, or other people who work with families with Medicaid in various forms are able to access health service needs, or I forget what was once called flex funds, for families to pay for things like, utilities, sometimes past due rent, or sometimes things like previous climate stuff has been like AC units or air filters for when the big like fire regions. And so thinking now to these other funds of money that will be available, through the years, right? You mentioned climate being the first one that folks can access in March. Will families still need, the process, it sounds like the process will now kind of not be so much apply for these funds directly to the CPO, but more to what you're identifying as health service related needs partners, and kind of not going through the CCOs anymore. Am I understanding that right? And will those funds still exist in addition to, or are all those funds going to go away from the CCOs managing them and go to these like partnership programs instead?
This is why I need that one pager about health-related services versus health-related social needs, because I want to have a quick, no-nonsense tool for you all, and I don't yet. And then Lisa, I think I'm right on this, but let me know. Health-related services have existed, will continue to exist. This is a new layer that is distinct. I do think that some things that are currently being paid for with health-related services funds will fit nicely into this new mechanism. And so there may be some things that are currently being paid with those HRS, health-related services, and the acronyms are so similar that it's really throwing me off too. So this is meant to be a new bolstering way of doing a little bit more in a slightly different way, and not meant to replace or to diminish any of the existing services and supports that are available either through CCOs or across the state through other mechanisms. And that's something that I think also is very very specific to our special terms and conditions with the federal government is we have to make sure we're adding new value. We're not here to replace or supplant anything that already exists or to get in the way of what's working.
Thank you. Yeah, no, that's helpful. I think what's currently available is small and limited and often not able to support some of the family needs emergently too that we have going on. So I think this will be a huge benefit for folks. So then essentially they could, you know, apply for those services through a CCO. Other thing, you know, it can get pretty outside the box, you can get covered through them, which is great. And then it sounds like other things like climate specifically coming up, they would apply for these services or funds or whatever this looks like, AC unit, air filters, whatever it ends up being available through these partner programs.
And I think it's going to run the full gamut. We're trying to build something that has multiple routes in. And I want to really say that the CCO continues to be a really central and useful way for folks to engage with these services as well.
I do want to make sure that there's clarity though, that HRSN is a Medicaid benefit. So if a member qualifies for the benefit, you know, meets the eligibility criteria, then they need to receive the benefit like any other Medicaid benefit. Where HRS is at the discretion of a CCO and it's actually not available to fee-for-service members. This is available to all OHP members. It is a Medicaid benefit as long as the member meets the eligibility criteria, which I know is a little vague for everyone right now. And that kind of gets to some of the earlier questions that you were asking about. That criteria will be when each of these services and benefits become available, that will be clear in all the systems and communicated out. But the members will, you know, they can, oh, what's it called when you don't receive a benefit? You can, oh my gosh, sorry, totally blanking. But just like any benefit, if you don't receive it, you can file a complaint. I mean, there are the requirements for them to receive that benefit. So I'm just really wanting to be clear that it is different fundamentally than HRS because it is a required appeal. Thank you. I don't know why I couldn't get that word. That's right. It's an appealable benefit, which is it's kind of a big significant difference for how these, benefits are going to reach members. And if it's not completed yet, there is a document that's going to be completed very soon. That's guidance around the difference between HRS and HRSN, and even share how those funds are used. And so we can follow up and share that back out. I know that the team is working on that and has been working on that. And that should be helpful too.
It's definitely another one of those resources that as soon as it becomes available, I'm going to be really excited to share it here. Also for my own, so I have good talking points and that I am more clear in these spaces, because I think it is it's a very confusing thing to think in the abstract. And when we have some more concrete details, I think it'll help us a lot. I did see, Sarah, your hand was up and went down and went back up. So I wanted to check in on you first. And I know we have a few more minutes.
Yeah, I was just thinking from a CBO perspective, when you're talking about becoming a Medicaid provider and needing to look into MMIS, if there are certain, for example, the person who asked about the Medicare things, if you're not well versed in the benefit packages of OHP and knowing that there's QMB, which isn't dual eligible, it's just a separate sort of subsidizing but doesn't offer you full benefits, how are you going to support CBOs who are in good faith thinking these folks are eligible because they don't necessarily understand the very different and complex benefit packages that are the Oregon Health Plan?
That is a great question.
Because in good faith, they could look at MMIS and see that there's coverage and not understand that even if that person is at risk of homelessness, they only have QMB, and QMB is not a benefit package that would necessarily support this, right? Because it's not considered full Medicaid and dual eligible. So how are those types of nuances going to be explained to folks if they're able to access this benefit outside the CCO, where the CCO would already be able to kind of like help clarify and flag folks that are eligible for those types of benefits?
Now I pulled up this slide. It's specific to outreach and engagement, but I think it has an important component on it that applies across the board, which is you'll see that there are the providers, and I'm sorry, I don't have this quite prepared. So imagine if this said HRSN providers, they have roles, but ultimately there is a different party that has to make the determination to authorize or deny services. So that's part of what is built in here. And I'm sorry, this is a very specific flow and not the broader one, but because it is the closest I have at my hand, I thought I'd pull it up just to show that the CCO does continue to be a really central player to the process by which people are able to access and the process by which providers are able to reimburse. And I also want to do this justice by focusing on it. It's going to be an integral part of the provider journey materials that we start to work with together next month, which I know is, I give a lot of answers that are incomplete, but I wonder if that helps at least a little.
Yeah, that helps. I just know, when we talk about some of these CBOs, especially those ones that are talking about being grassroots and haven't really participated in Medicaid in a way that makes them like a Medicaid provider, which has its own set of nuances when you officially become a Medicaid provider. I'm just hoping that there's safeguards in place for people that don't understand how to navigate the nuances of Medicaid, which can be complex even for an actual like medical provider.
Absolutely. I think that's really the crux of what we want to do here over 2024 as well. I want to learn how to do that well too. And there will be times where the answers aren't satisfying. There'll be things that I think we can work on together to make better. There's my answer for now. We are at time and there's still hands. I'm gonna offer, George, do you want to keep talking offline? I can reach out to you if you can put your contact information, if you can send it my way. I don't want to skip over your hand, but I also want to honor everyone's time. And I know that we've reached the end of ours today. Does that work for you?
Yeah, I was just kind of curious how HUD played into this. That's all that I wanted to, was curious.
Yeah. I want to thank you all for being here. And for those of you who, I know we've lost quite a few people probably because people had other places they needed to go at 3. We will be back February 13th. We will send you more information to register for that session, and we'll continue to build these things out. This was really, really helpful feedback, and the questions I was not able to answer will be the things that are energizing me into our next session. And we'll keep chipping away at this really big, complex set of things that we're working to build. Have a great rest of your day. Have a great rest of your January, and we hope to see you very soon. And you hopefully know how to reach us in between, but if you don't, I'm happy to see how I can help connect and convene where I can. Thank you again. I'm going to close out in just about another minute. I'm just going to keep the chat open for a little bit longer.